Thank you very much, Samina, for those kind introductions, and I'd like to thank PEDRI for inviting me today. So, vital role of equity, diversity, inclusion in data research. I'm going to mainly concentrate on the ethnicity aspects, because that's where we've done the most work in, but it also applies to all the protected characteristics, and I'll mention them in my presentation. So these are my disclosures. So the next few minutes I'll go through the background, the need for ethnicity minority representation in research, the current representation of ethnic minority participants, barriers, and potential some solutions. So in terms of background, I don't think we'd be talking here today if it wasn't for COVID. COVID really catapulted ethnicity into the front line because we saw the tremendous impact COVID had on people of different ethnic backgrounds, particularly the minority ethnic backgrounds. One of the things, good things that have come out, there's a few, is the terminology. So previously we used to call people of BAME origin or BME origin, and this is a term that most ethnic minorities don't like. And so we did some work, and now I think it's been accepted that we really should be using the term ethnic minority populations when we are collectively talking about ethnic minorities. But if we're talking about one minority group, then refer to them as that minority group. Why is it important? Well, this is data from England and Wales, from ONS. The difference and the change in the composition of ethnic minority populations and our population as a whole since 2011 and 2021. As you can see, there's been a huge increase in ethnic minority populations, 5.5 million, 9.3% Asians, 2.4 million black populations, 1.7 mixed, and 1.3 million other ethnic groups. On the right-hand side, you see the increase in certain groups, particularly in the Indian, Pakistani, and other white groups as well. So is research inclusive? Well, we really should be thinking when we conduct our research in all protected characteristics, which you all know is age, gender, ethnicity, disability, marital status, religion, pregnancy, maternity, sexual orientation, gender reassignment, and social status. Socioeconomic status. And most of the time when we do in our work, we look at the intersectionality of some of these aspects as well, which is really important. So why is it important to be inclusive? Well, if you look at clinical trials, I don't think the pointer works. We don't have a pointer. If you look at clinical trials, that's the narrow triangle. Clinical trial populations are very narrow, very tight inclusion-exclusion criteria. We generate evidence from that, and then that trial evidence is being applied to the real world setting. So this is people who may not be in the trial and may not apply to those inclusion-exclusion criteria, so we say off-label, or diverse populations. The study may have been done in certain populations that are totally excluded from the trials, but then we're trying to apply them in the real world setting. And this is where we say you see the efficacy in a randomized controlled trial, but what we need to see is the effectiveness in the real world setting. So trial evidence is for a small population, but there's very little evidence for the population that we're trying to apply that evidence to in routine clinical practice. So the reason it's important is, first of all, we've got a diverse population, and we, I think, have the best data in the world in terms of not just the data, but the ethnicity data as well. And HDR UK have played a massive role in this area. And this is that came out right at the beginning. This is, as you will see, published on the 20th of April. The first data on ethnicity and COVID in the UK came in the first few weeks of February and March, when you saw ethnic minority healthcare professionals who were dying. And then the data were published from the intensive care unit for the first data showing that it was double the proportion of people that was suggested by ONS to be in the UK, and suddenly the signal started. And we wrote an editorial within the first week of that data coming out and explored why it was the case that ethnic minority populations were affected. And since then, there's been a huge amount of work, including with the HDR UK as well. But this is the need for good quality ethnicity data, and this is from HDR UK, and we see measuring, understanding variation is important because it informs clinical practice. We can use that data to plan health and social care resources. We can target impact of service improvements if we've identified gaps there. We can look at national interventions or national disasters. So COVID was a case that we certainly looked at in detail. And because we had such good data, COVID was there in Hong Kong, China, Italy, well before us, but they didn't have the data. It was us in the UK who alerted the world that there were issues here with certain populations. And then we can use these data for allocation of research funding as well. Just to give you an example, this is data for the area I work in, cardiometabolic. So a lot of the examples will be from cardiometabolic. Hypertensive disease, stroke, chronic ischemic heart disease, myocardial infarction, heart failure. Now, what we tend to do is lump all ethnic minorities in certain groups. So South Asians would be one group, blacks would be another group. South Asians are a heterogeneous group. There's Pakistanis, there's Indians, there's Bangladeshis. And when you look at this data for hypertension, for example, you see Bangladeshis, Black Caribbeans, Pakistanis having the highest rates. Indians lower and Black Africans lower. Things change around a little bit when you look at myocardial infarction. So it's really important to have that granular data at that specific ethnic subcategory as far as we can. And to give you an example why this is important, this is data from randomized controlled trials. This is a systematic review we just recently completed a year ago. SGLT2s, GLP-1s, you probably doesn't mean anything to you. GLP-1s will, because Mounjaro, everyone's heard of Mounjaro, the weight-reducing drug. That's GLP-1. And that has a massive benefit for reducing cardiovascular disease, kidney disease, and heart failure. And all the trials have said they're great for these people, SGLT2s similarly, and all the guidelines say we should be using them for these populations. But when we looked at all the randomized controlled trials that have been published globally, we see that overall there's a 8% reduction for MACE, which is major adverse cardiovascular event, for the white group. 31% relative risk reduction, much greater reduction in the Asian group. No significant difference in the black group. But the guidelines are saying we should be using this drug in everyone who has those diseases. Now, we don't know why there are these differences. And unless those patients are recruited to trials and we've got data for those trials, we wouldn't have had this type of a signal. So now we need to go to the basic level, pathophysiological level, or molecular level to say, are there certain differences and why are these differences? Similarly, when we see that the guidelines are recommending these therapies, SGLT2 inhibitors for kidney disease, NICE are recommending these, and this is work we did with the London School of Tropical Medicine and Hygiene. We see these are fantastic drugs and very, very cost effective. We see that suddenly those drugs on the right-hand side, the SGLT2 inhibitors, there's a massive difference in utilization of these therapies in England. So those people who have the highest risk, ethnic minorities, South Asians and blacks at the highest risk of cardiovascular disease, kidney disease, they're less likely to get these therapies. Deprived populations who are also at the highest risk are also less likely to get this. And these are data from general practitioners prescribing these therapies. So excellent evidence base, guidelines telling us that we need to do this, but it's not being utilized in clinical practice. Now, unless we have that data, we wouldn't be able to see this. So now we can think about and say, what are the interventions we can use to improve these outcomes? Similarly, hypoglycemia. We have data for hypoglycemia that overall, this is data we've looked at by ethnic groups, that non-white ethnic groups have less hypoglycemia. And Andrew will probably know from Dundee days, I was at Dundee as well, when he was doing diabetes, hypoglycemia is not a good thing to have. But this is data showing that non-whites don't get it as much. And the reason is it true result or is it the way it's been assessed? All the data on hypoglycemia have been done what we call clamp testing, really, really intensive monitoring where they drop the glucose down and then look at the symptoms patients having. It's all been done in white populations, not in a wide range of ethnic minority populations. So all the cut points we have of hypoglycemia, which is 4 millimoles of glucose per liter, is based on all the data that's been generated from white populations. So what about current representation from trials? This is from US race ethnicity representation on over 20,000 trials, an incredible study. And what they did was they looked at the US Census and the data from the US Census compared to the trials. And overall, you can see for overall Latino, Black, Asian, American Indians, there's less participation of these ethnic minorities than the census population for the US. These are studies looking at diabetes trials. Again, large study, 405 trials. And again, we see overall less representation. And in the UK, things haven't improved from 2000 to 2020. 20 years, not improvement in recruitment for ethnic minority populations into these trials. The area we'll be talking a lot about in the future is multiple long-term conditions or multimorbidity. We don't use multimorbidity. Patients don't like that term. They say we're not morbid. So in the UK, we've embraced the term multiple long-term conditions. People are living longer. We're not going to be talking about diabetes. We're not talking about heart failure or heart attacks or kidney disease. We're going to be talking about multiple long-term conditions because the majority of the people will have multiple long-term conditions. And this is data. Again, we can do this because we have the best data. We looked at this data for the whole of England, 60 million people in this data, showing that multiple long-term conditions increase from the age of around 30, and they are more prevalent in Asians and Black populations. So we need to be doing studies to ensure that these populations are represented. Zaya Kayani did a systematic review. She's a PhD student with us, looking at all the studies that have been done on multiple long-term conditions, which is only 13 studies. Only 4 reported ethnicity information. 3 out of the 4 mainly included white participants, and overall ethnic groups were underrepresented. Majority of studies did report on socioeconomic status of the participants, which is good news, but ethnicity wasn't reported as well. This is data on these fantastic trials, as I said, the Mounjaro type GLP-1 receptor agonist, and we did a systematic review of those trials, saying ethnic minorities are underrepresented. Ethnic minorities are more affected by these. But overall, all of these trials, ethnic minorities were less represented in these studies. Coming to COVID, again, we looked at a systematic review and a meta-analysis of all the COVID trials, which was quite large numbers, and these were all the ones that were being conducted in the UK, and we compared it to the ONS population. So if you look at this white populations, 84% overall recruitment, but if you look at the Black, Asians, and mixed, you're talking less than 6%, 1 to 2% representation in these trials. And when you deep dive into the systematic review, none of the studies gave any data on how many were approached, how many were screened in terms of ethnic minorities, how many were eligible for inclusion. It said 17 trials, 52,000 participants, but no data on eligibility of criteria, followed up for primary endpoint, followed up at longest follow-up, what effect size estimates were in these trials. Even though they didn't recruit as much, they didn't give any other further data at all. So what are the barriers? Well, a huge number of barriers, language, lack of awareness of research, time, costs, location is very important, cultural non-competence of the researchers, lack of efforts by researchers, negative perceptions, particularly coming from researchers, mistrust comes time and again, particularly for Black populations. Prior experience, mistreatment previously, disrespectful, and subpar care in non-English speaking speakers. And just to give you that, we can't say there's one barrier for all of them. We need to deep dive into each ethnic group, and this is what we did. We did some work for NIHR to try and increase representation of ethnic minorities in the national NIHR trials. And so when we go and speak to them, South Asians have very different barriers, and their facilitators are different. African and Afro-Caribbeans have different barriers, and again, we need to tackle that. Gypsy and Roma have very, very different barriers, and we need to look at those and say, how can we facilitate that? So really, whatever target population we have, we need to identify barriers individually. We can't say one size fits all, and then develop strategies to improve recruitment accordingly. And they also vary by trial to trial. There were specific barriers to the COVID trials from certain populations. Language is a major, major issue. This is looking at percentage of people in each level of English language skills by ethnicity. And on the right-hand side, you see the dark area where main language could not speak English well, and lighter area, main language English could not speak at all. And you see there's quite a lot of people who do not speak English at all, and we really need to bear that in mind when we are looking to recruit ethnic minority participants. We often say lost in translation. This is something we looked at during COVID. As we've said, high rates of COVID in ethnic minorities, but when you look at the data on long COVID, very little data there at all. And there's mixed data some showing there may be no difference, some showing there's a lower prevalence of long COVID in ethnic minority populations. And we're saying this just can't be right, because there is a pathophysiological mechanism, inflammatory markers, all of that have been shown in ethnic minorities to show long COVID. But the way it's assessed is very, very different. There are validated questionnaires for long COVID, but none of them have been translated. And the way translation needs to be done, I'll come to shortly. It's not just looking at forward translation, back translation. That doesn't work. There's a lot more nuanced work you need to do. So we think this is because of language barriers, interpretation of symptoms, cultural norms. Tiredness is very normal in some ethnic minority populations. So, tiredness is one of the key features of long COVID, but that's normal in some ethnic minorities. And obviously communication barriers as well. So what can we do about this? This is, again, data from HDI UK. We were fortunate enough to win the Team Science Award for this. Myself and Ashley Akbari led this work on recording of ethnicity data that we really should be improving. And these were the 5 recommendations. Consistency in data collection. We've been talking about many of these issues today. Standardization, communication transparency, completeness through data linkage, but the most important is training and guidance. There are no training courses on how to collect ethnicity data, and we've asked so many people within the NHS in the research environment, and this is something we're hoping to develop something. NHS England asked us to do a scoping review on how to improve inclusion diversity, and these are some of the recommendations that are in the paper. Taking a personal approach, building community partnerships. That's how we're doing many of our work. We have community champions who work within the community. Culture and humility and competency training. Everyone who's doing research should have culture competency training. Increasing understanding and trust multilingual materials and staff. These are 8 recommendations from the STRIDE. This is with Professor Trevick we're working with in Aberdeen. Again, very, very simple recommendations. One thing we're suggesting here is for some trials, particularly where we think it's an issue, we should have representation of that ethnic minority population. For example, diabetes affects black populations and South Asians more. We should have at least equivalent representation to ONS data that's showing what proportion are in England or UK equivalent population. Frameworks for developing translated material. Not many people talk about this. We do work in developing diabetes risk score. And one of the questions then, what's your BMI? There is no Asian word for BMI. Okay? How do you communicate that to someone when there's no Asian word for BMI? So each of these languages we translated to took us 8 weeks to develop to get the nuance of that word BMI. Prostate cancer, anyone work in prostate cancer? There is no work for prostate in ethnic languages. So when I do the community work, I have to use very rude words when I'm describing the prostate. Innovative interventions to overcome barriers. There are still many South Asian ladies and men who use DVDs. And these are kind of things that we need to bear in mind when we are communicating interventions to these populations. Novel methods of recruitment. If you send a letter out from the GP surgery, you get a 5% response rate in Leicester. So now we're using different methods. We go through communities, community champions. This is a pilot study we did in 3 faith centers. And within 3 days, we consented 202 participants at these events. And that's a method we're using more and more. And this is not just for South Asians, even for black populations going through the black churches. Overcoming barriers through culture competency training, effective community engagement, looking at conceptual equivalence rather than the linguistic equivalence, core development of resources. A lot of this was presented earlier on. If you want any of this information and these resources, they're at the Center for Ethnic Health Research. You can download many of these free of charge. There's a website at the bottom. And I think funders and journals are playing a big role as well. And they have to. Researchers want to get them published in the biggest journals. They want their papers published by guideline developers as well. So now there are funders such as Diabetes UK and IHR that are making it mandatory that we do need to have EDI in all the studies. Journals are now saying that we do need diversity data collection, not just for the participants, but even for the authors as well, which is great news. So in summary, there's a huge scope for improving ethnic minority and other protected characteristics in trials. We need better monitoring of participation. As a UK, we're overall good for big data. We can still improve. There are some differences there, which we can talk about later. We need to think about proportional representation for certain protected characteristics in certain trials. We need to make funders aware that it does make a difference in having proportional representation, but it does cost money to invest and try and get more patients from those ethnic minority backgrounds recruited. It's not as easy as it is with certain populations. And we really need to highlight inclusive research at every opportunity. And capacity development, there was a question earlier, it's very, very important. We have the next lot of research and workforce that is trained to do this work. And finally, we all need to collectively work to conduct more inclusive research to ensure evidence generated does indeed reduce disparities. Thank you very much.